Hi, Emily. Thank you for joining us on MD Newsline. Can you please introduce yourself for our audience?
Absolutely. Thank you so much for the opportunity to be here. My name is Emily Zboril. I am a fifth-year PhD student at Virginia Commonwealth University, so I'm in the last year of my doctoral training.
Yeah, and you had a really interesting poster here at the Endocrine Society 2025 annual meeting. Can you please tell us a little bit about your work and your research?
Absolutely, I would love to. So I study bone metastasis of ER-positive breast cancer and the clinical challenge in treating patients with this type of metastasis. So ER-positive breast cancer, the ER stands for estrogen receptor positive breast cancer. These cells are driven by estrogen signaling to grow and proliferate. And what's really interesting about bone metastasis of this type of cancer is that cells in the bone microenvironment are really tightly regulated by sex hormones like estrogen. And the drugs we treat patients with in the advanced and metastatic setting usually downregulate or degrade the estrogen receptor in a universal way. So fulvestrant, elacestrant is a new compound that's been approved for a couple of years. What these drugs do is they just kind of ablate estrogen receptor signaling in both the cancer cells and the bone microenvironment. And this can lead to symptoms like bone pain, osteoporosis, increased risk of fracture. But there's some evidence to suggest that this osteoporosis can sort of exacerbate or accelerate metastatic outgrowth in the microenvironment. Because if you can imagine, bone tissue is a hard space. And so when the metastatic cells come in, part of their activity is to resorb bone and cause osteoclast bone resorption to sort of carve out a niche within the bone tissue. And so we think that by finding new treatments that will be bone protective while still downregulating estrogen signaling in the cancer cells, we can provide patients with not only better treatments, but treatments with less side effects. And so my poster and my talk was all about Lasofoxifene, which is a new compound. It's in a phase 3 clinical trial with abemaciclib versus fulvestrant and abemaciclib for patients with advanced metastatic ER-positive, ER-mutant disease. And so what I'm really focused on is lasofoxifene as a monoagent in the bone metastatic setting. This drug is approved in some countries for osteoporosis treatment, so it's known to be bone protective, which is an important part of interrupting this crosstalk between the metastatic cells and the bone cells. And we've also shown that it's very effective in preclinical models at reducing overall metastasis as well as bone-only metastasis, which is really exciting for us. And we think that that has something to do with this partial agonist activity. And when I say agonist activity, essentially what I mean is that the same compound can stimulate the estrogen receptor to transcribe genes in the bone cells, similar to estrogen, but can downregulate or antagonize ER in the metastatic cells in the bone microenvironment. And we think that this is due to recruitment of transcription factors that are different in the two different cell types. So particularly, we're interested in osteoblasts in the bone. So these are the cells that make bone matrix and calcify it. They're the bone-producing cells. And we think that lasofoxifene enters these cells and binds the estrogen receptor, and it goes to the DNA and recruits proteins to turn on genes to make more osteoblasts or stimulate osteoblasts to make bone. And that these proteins are different between the osteoblasts and the cancer cells in the bone microenvironment. And so that's sort of the next step of our work, is to prove that mechanism, to see what the proteins are that are changing the transcriptional capacity of ER under lasofoxifene-stimulated conditions. And additionally, to find novel combinations. So we're really interested in endocrine therapies with other inhibitors. So we are looking at different cell cycle inhibitors that can preserve the viability of osteoblasts or other cells within the bone that are important for homeostasis while still decreasing metastatic burden, with the hope of finding something to enhance this mechanism so that patients can have better outcomes, longer survival, because right now bone metastasis is not a curable condition. So patients who receive this diagnosis will die with it. And so it's really critical that we find new treatments, combination treatments, to provide a better standard of care for patients with bone metastasis of ER-positive breast cancer.